from the Limi Children's Hospital. We are sorry for the slight delay we've had. We'll proceed immediately. Today we'll be talking about managing cardiometabolic risks in pediatric patients. Yeah. So with me today is a colleague.
I'm Dr. Sani Zuliat.
All right, thank you. So I'm Dr. Igoche Peter. Yes. Okay, so why are we making this presentation today? The topic looks a little adult, a little pediatric. Why are we making this today?
Yes, so it's very important because when people think of pediatrics, they are thinking of infectious diseases, different things like that. So it's very important to raise physicians' attention to the emerging importance of incorporating preventive practices against cardiovascular diseases because much attention has been paid into infectious diseases generally and then even in the pediatric age group. Yeah. So I think you need to ask yourself, when was the last time that you measured the blood pressure of a pediatric patient? Or when was the last time you requested for the lipid profile of a pediatric patient?
Yeah.
So I think that will be able to guide you to see the importance of this topic today.
Yes. So even in the practice of pediatric cardiology, a lot of emphasis has been on congenital heart diseases, rheumatic heart diseases, but preventive pediatric cardiology has received very little attention. So you ask ourselves a question: have you ever requested for lipid profile? That's to our dear listeners now. Have you ever requested for lipid profile of a pediatric patient within the last 24 months of clinical practice? And that's a very serious question, right? Okay. So we will make progress with our presentation. So we have an outline in front of us. Yeah, we'll make a brief introduction. We'll list the cardiovascular risk factors. I know that biochemistry is not something that is very attractive to so many people. So we'll just summarize and gloss over it, then get into the specifics of the risk factors, talk about screening, and then the guidelines. Okay.
So by way of introduction, the burden of cardiometabolic risk factors amongst children and adolescents is high. So, and at least one risk factor was present in a study by Akim Budewa et al. Was present in 68.4% of the subjects. You can see how high
almost two-thirds.
Yes.
Two-thirds of
the subjects, yes. And hypertension accounted for 12.3%. Hypertension accounted for male versus female 11.9 versus 1.8. Meaning it was more among the males.
Why? It's all right. And then overweight was almost 10%. And the non-high-density lipoprotein cholesterol was elevated in almost 40% of subjects. Then 1/3 of them had elevated low-density lipoprotein. Yeah. Okay, fine. So we make progress. So we understand that clustering of the cardiometabolic risk factors occur in early childhood, and this is talking about childhood onset of adult diseases. Now, these children have this cluster, and then there's a rise in pediatric obesity, even from the study that was used as our introduction. And this will automatically increase the prevalence of type 2 DM, hypertension, dyslipidemia, and even the non-alcoholic fatty liver. All these set up the environment, the ecosystem that will eventually result in cardiovascular complications.
So in terms of cardiovascular risk, we can look at it like this, that before the onset of symptoms, how can we be able to detect this early? So looking at the biochemical parameters, and that's the dyslipidemia, including the hypercholesterolemia. So that's a cardiovascular risk factor. Then lifestyle, which is a very, very important risk factor because a lot of all these, if not all of them, the lifestyle are precursors to a lot of all these cardiovascular risk factors. Yes. Sedentary lifestyles, a lot of children now gaming, sitting in front of the TV.
So children are driven from their house in their parents' cars to school.
Yes.
And in the school, not much space to play during break time. they are driven back, and every child now has an iPad,
Yes.
right? Just
So-
to make the parents focus on more important things.
things. And so these are some of the risk factors. Then smoking, in your mind, you'll be like, smoking, pediatrics, yes, smoking, pediatric, because you know when we're talking of pediatrics, also includes the adolescent age group from 10 to 19. So, and you agree with me that a lot of adolescents actually smoke.
Yeah.
And when we're talking of smoking, we're not just talking of cigarettes, we're talking of shisha. A lot of people think shisha is just flavored smoke or something.
Looks
No.
fashionable.
Yes. So it has a lot of harmful substances as well, including nicotine, carbon monoxide, and it also has the risk factors that are associated with smoking as well.
Yeah.
Alcohol intake.
Yeah, and even on smoking, even those who are not smoking but they are in the environment where
Yes.
the smoke is going on. So that's the second-hand smoking.
Yes.
Even
So-
in fact, very, very dangerous too.
Then alcohol intake from peer influence, peer pressures, and then the clinical diagnosis. There are some conditions that are actually cardiovascular risk themselves, like hypertension, diabetes, chronic kidney disease, nephrotic syndromes, and some chronic inflammatory conditions like systemic lupus erythematosus, juvenile rheumatoid arthritis. These are some of the cardiovascular risks.
Yeah, it's okay, fine. So let's just touch lipid biochemistry, just the highlights, right? So we have the lipids, because we said dyslipidemia. The first one we mentioned was dyslipidemia as a risk factor. So we have the lipids in plasma and the other components of plasma that transport these lipids. Those are lipoproteins. So the lipids of interest are cholesterol, triglycerides, phospholipids, free fatty acids. But we'll just focus on cholesterol and triglycerides in the presentation today. Now, we know that cholesterol is not all bad because it's necessary in as a precursor for various hormones and bile acid metabolism. We'll see the importance shortly. Now, these lipids are transported as lipoproteins. Yeah, and we have the ApoB lipoproteins, B for bad. Okay, and apoprotein, A for acceptable, right? Okay, fine. Yeah.
So for the B lipoproteins, they are the atherogenic ones and they are the ones listed. What is to note is the low density lipoprotein, which transports 65% of total cholesterol. So you can see the importance of LDL in assessing for cardiovascular risk.
So the higher the LDL, the more cholesterol it's containing.
Yes. And then the ApoAI containing lipoproteins, which are the non-atherogenic, that's the high density, which is protective.
Yeah. All right. Okay, fine. So low density lipoprotein, that's the culprit, the major culprit here, right? So we look at low density lipoprotein from two perspectives, qualitatively and quantitatively. Qualitatively, in terms of particle size, if it can be assessed in that specific laboratory. Also, and quantitatively in terms of the quantity. But the smaller the particles, the greater the risk of atherogenesis, formation of plaques, because it can permeate into the intima of the vessels and form plaques. So the small dense lipoprotein phenotypes are been found to be associated, even though some labs will not be able to measure it. But we assume when triglyceride is high and high density lipoprotein is low, it's taken that that picture is usually associated with presence of the small dense lipoprotein. And these are features of obesity, metabolic syndrome, which we'll talk about in details shortly, and type 2 DM. It's okay. So, yeah, so we have this formula here, the Fredwald formula for calculating low density lipoproteins. That's to quantify it. So provided we can measure the total cholesterol, we can measure the high density lipoproteins, and we can measure the triglycerides. Through this formula, we can derive the low density lipoprotein. Now, but this formula is reasonable if and only if the child is fasting. Now, lipid profile can be fasting or non-fasting, right? But if you want to derive the low density lipoprotein, then it's a child fasting. And the triglyceride must be less than 400 milligram per dl in the absence of chylomicrons or other beta lipoprotein. In the event that the triglyceride is higher than 400, then it's better to, you can measure it directly from the space mark. Yeah, it's okay. So the dyslipidemias, this is number one.
Yes, sir. So in the dyslipidemia, how do we assess them? Usually laboratory diagnosis.
Yes.
Usually say 12 hours of fasting. But you might ask, how do you tell a child to fast? Well, we'll talk about that later when you see the age group of people we are assessing this, so you know that they can actually fast.
Yes.
So the common one we do is the HDL, the LDL, and the triglyceride and the total cholesterol.
Yes.
And then we can do extended profile, which includes the very low density lipoproteins and the non-HDL cholesterol, and the ratio of the total cholesterol to HDL,
Yeah.
which includes all the atherogenic index.
Yeah, so this non-high density lipoprotein, dear listeners, pay attention to it because we'll expatiate more on it going forward. Yeah, specific types. So we have specific types of these lipidemias. We've talked about the laboratory assay. Now, if total cholesterol is elevated, hypercholesterolemia. Yeah, so there is also when the low density lipoprotein that transports about 65% of cholesterol in plasma, that is also found to be elevated, and all the other types. Now, when high density lipoprotein cholesterol is lower than normal, so we have every other one going up, being bad, and then if the high density lipoprotein is low, that is bad. So we'll bear this relationship between them as we progress.
So this is just a slide showing the concentration. We're not going to be reading it out, just supporting what he has said, that the higher the other cholesterol, the worse, and then the lower the LDL, I mean the HDL, then the bad. So it's that's what we need to put into. We'll get all the slides.
Yeah. So let's look at cardiovascular risk assessment from the lipid profile, the derivatives of lipid profile, right? So we are looking at dyslipidemia. We earlier said we pay attention to the non-high density lipoprotein cholesterol. So if we take total cholesterol, because we know that the lipoproteins transport cholesterol in plasma, if we subtract the high density lipoprotein cholesterol from total cholesterol, what we get is the non-high density. So there are lots of other lipoproteins that are just lumped together in that under the umbrella non-high density lipoprotein. So all the other lipoproteins that are not high density. So it includes all the classes of atherogenic lipoprotein, like very low density lipoproteins from the extended lipid profile, the low density lipoproteins, and all this, because it's a better screening tool than just focusing on low density lipoprotein, which is just one of the non-high density lipoprotein. Yeah.
And then the total cholesterol to HDL cholesterol ratio, which is the atherogenic index. So, and some of you may be used to the adult value 5, 4.2, but in children it's approximately 3.
Yeah.
So,
yes.
So higher ratios than 3 portends a greater cardiovascular risk for them. And then the small dense LDL that we talked about earlier that have more atherogenic and the property of forming more plaques and cholesterol plaques. So they're actually more important than the total. And some labs actually mention them. But like you said, there are some ways you can know that, okay, you have high triglycerides, depressed HDL, then usually associated with this small dense like LDL particles.
Yes. Okay, so how do we manage dyslipidemias? For the purpose of this presentation today, we will just talk about two of the dyslipidemias, hypercholesterolemia and hypertriglyceridemia. Yes. So management of hypercholesterolemia.
So in terms of management of hypercholesterolemia, it would be nice if we manage the child as a whole.
Yes.
Right? We're managing the child, looking at all the things that could have precipitated, aggravated, or anything that could have led to this. So starting with diet, for instance, we're going to counsel them on reduction of saturated fat. Saturated fat and hydrogenated fats, those are fats that are solid in room temperature, like butter, ghee. They are also contained in pastries, cakes, and all a lot of junk food and cholesterol. And another very important one is the child-born diet. Child, not for pediatric.
So let the child take child diet. A child-friendly diet. So child-born diet.
Yes.
That's cardiovascular health integrated lifestyle diet 1.
Yes. So, and it's also used for other cardiovascular risk. But now that we're talking about hypercholesterolemia, we'll talk about the specifics later on. So basically, after you try this diet, our target is to reduce the LDL to less than 130 or equal to 130 milligram per dl in 6 months.
Yeah.
So if this now fails, we go to child 2 diet for LDL.
Yes. Okay. So because so good, there's child 1 diet. There's child, which is general for the dyslipidemias. Then there's a child 2 diet specific for low density lipoprotein, because the low density lipoprotein transports the highest percentage of cholesterol. But there's also the child 2 diet for elevated triglycerides. So 6 months on child 1 diet, 6 months, if he fails, another 6 months on child 2 diet. We shall discuss in the next slide the components of the child diet. Now, but in case or after we've done child 1, child 2, and it fails, right? That is to say, dietary intervention has been done for 12 months and it is failed. So we get the average of 2 fasting lipid profiles, taking at least 2 weeks apart, but not more than 3 months apart, as the baseline before drugs can start. We'll look at drugs as we progress.
Okay, so these are I'm sure you're wondering, well, how would I tell my patients take less than 30% of fat or 7 to 10%? So the management of cardiovascular risk factor, it is not a job done in isolation.
Yeah,
it's a
multidisciplinary.
So it's something that you need the collaboration of other healthcare workers like the dietitian. So once you tell the dietitians that, okay, this is what you need for this person, they know how to fashion out a timetable for the child to culturally acceptable food that will meet all these criteria for the child 1 or the child 2 diet.
Yes. All right. So enough of child 1, child 2 for the children. So what of drug therapy?
Yes. So now after the child 1, child 2 has failed, right? So we need to now move to pharmacotherapy. So what are the indications for the pharmacotherapy? So I'm sure we're all seeing the slide. So there's need to tell us what we mean by high level risk factors, moderate level risk factors. So high level risk factors include hypertension, that's the patient hypertensive on drugs, smokes, then the BMI is greater than the 97 percentile, has diabetic mellitus, has chronic kidney disease or Kawasaki disease with current aneurysm. Then the moderate level risk factors are the ones that have hypertension but they're on lifestyle modification. Then the BMI is between the 95th to less than the 97th percentile. Then when you have the HDL less than 40 milligram per dl, or other chronic inflammatory conditions like SLE, Jeffrey syndrome. So now let's just practicalize this. For instance, you have an 11-year-old, right? 11-year-old with LDL greater than or in LDL of 195, you start treatment. Pharmacologic treatment. You have an 11-year-old with LDL of 170 with a father had MI, for instance, you start pharmacologic treatment. So these are just bringing it to
so it means we must take family history. Beyond treating sore throat, beyond treating diarrhea disease, beyond treating malaria, family history. So taking care of this cardiovascular is a very intentional aspect of clinical practice, right? So that's so we see the categorization between greater than or equal to 190, between 160 and that 190, and then below it. So but very importantly, we must know that these drugs are not for very young children, right? So greater than or equal to 10 years, right? But if we have children aged between 9 and 10, 8 and 9, which is close, with the values persistently greater than the upper limit, right? Then we will also need to treat. So the drugs.
So these are some of the drugs that we commonly use. The bile acid sequestrants, which usually they're used for LDL, elevated LDLs. Then the HMG CoAs, the statins that were all common, usually used for LDL. It also has minimally minimally reduces, increases HDL levels as well.
Yeah.
Then the cholesterol absorption,
There's a team. Yeah.
Which also works
maybe
with-
Aliboman found the drug. It's a very nice name.
Yes.
Yeah, so then the fibrates for elevated
Triglycerides.
triglycerides. Okay, fine. Yeah, so how do we manage? So we've talked about management of hypercholesterolemia, which is one of the dyslipidemias, right? So we're now looking at elevated triglyceridemia, which is another dyslipidemia. These are the two we are discussing today in terms of dyslipidemias. So again, diet, lifestyle, even the third one is still around diets, right? Good. So we assume that child one diet is for all of them. Now we'll now try the child two diet that is specific for triglycerides. Uh, we, which the components were discussed in the previous slides. Note that high carbohydrate diets can cause elevated triglycerides. In fact, more than high fat intake. So it's through lipogenesis from substrates that are primarily carbohydrates. So intake should be very, very.
So that's why in the child 2 triglyceride diet, it talks about taking more of complex carbohydrates and then increasing healthy fats.
Yes. Okay, so lifestyle modification.
Yes, lifestyle modification, and that's an exercise. It says greater than or equal to 30 minutes of moderate intensity exercise 5 days per week. So when we are prescribing exercise, we are not just prescribing, oh, just go and do exercise. You have to be specific. So you are talking about the intensity, the time, which we talk about when we're managing obesity.
Yes.
Okay. So, and then the intake of dietary fish. You can just tell them to increase their fish intake, but then when you think you need supplements, then we can prescribe 4 to 8 grams per day.
Yeah, omega-3 fatty acid. All right, so we have spent some time talking about the dyslipidemias as the first cardiometabolic. So we go to obesity, right? So and the related cardiovascular risk are clustered together. Know that the atherogenic dyslipidemias, with they are also called the lipid triad. So we have a collection of these three things. One, when triglycerides are elevated, right? When we have presence of the small, dense lipoprotein particles, when we have lower than normal levels of high density lipoproteins. Remember we said that these three go together, right? So even if the laboratory we have cannot measure, cannot quantify, get the quality of the low density lipoprotein particles, if we have elevated triglycerides and decreased high density lipoproteins, assume it goes together. With insulin resistance like hyperinsulinemia, talking about type 2 DM now, and then presence of pro-inflammatory conditions or pro-thrombotic states, it forms that triad. So if in one person we have all these three, is a metabolic syndrome, right? So we are talking of obesity as a type 2, but now when the obesity is truncal, abdominal obesity, then we have this cluster commoner among such people. Yeah. Okay.
So talking about the definition of metabolic syndrome in adults and children, we can see there's quite some differences or a lot of differences between, because in adults we have exact values of the waist circumference, whereas in children and adolescents we have to use the percentile.
So that's the beauty of pediatrics. People, we have children of various ages, right? So we will not work with just one value. I mean, the waist circumference of an adult fixed at 102, greater than that being obesity based on waist circumference. But we have age and gender dependent percentile charts for pediatrics. So if it's greater than or equal to 90th percentile for the child, then that is obesity. But in case we have a child that the measurement is above the adult cutoff of 102, that qualifies also, right? Yeah.
So for the children, you can also see that obesity is very important in the diagnosis, unlike the adult where it's 3 or more criteria of all the listed ones.
Yeah.
But for children, it's obesity plus 2 or more of those criteria.
Yeah. So if we have systolic blood pressure greater than 130, or diastolic blood pressure greater than the 85th percentile 85th millimeter, we will say this is hypertension for them, right? The blood sugar, elevated fasting plasma glucose level is also stated. Okay, coming down to obesity in Nigeria.
Yeah, so according to the Global Obesity Observatory, it's been said that that the prevalence of obesity is rapidly rising everywhere, even more so in Africa.
Yeah. But why? Just like in education, are people eating enough? So we have the problem of infectious disease, and then are people eating enough? Why obesity? Well, I think the answer may not be too far-fetched. Looking at when we say the double burden of disease is what Africa and Nigeria inclusive is currently facing, where you have high burden of infectious diseases and then a rising trend of non-communicable diseases. Why do we have that trend? Westernization. Our lifestyle is getting westernized, so we find this present. So why some people are obese because they are eating healthy in quote but too much quantity, others are obese because they are eating junk and it is getting into obesity.
Yes, I think that's a good explanation.
Yeah.
So in terms of the prevalence, the boys overweight, was about 10.3%, and then the obesity was 8.3% in boys. Whereas in girls, overweight was 16.7%, so it was higher in girls than obesity as well.
So in this case, the girls are doing better.
They are doing good.
Okay, fine.
So in terms of etiology, we talk about nurture and nature, right? So what's the etiology of obesity? There's the genetic predisposition, of course, apart from the genetic chromosomal, like Fragile X syndrome or Prader-Willis, those are there. Then we also have to think about endocrine. Also endocrine causes as well, like
hypothyroidism,
yes, Cushing syndrome, polycystic ovarian syndrome, which is quite common now amongst adolescents. Then we also have to talk about the nurture, that's the environment, which we talked about the westernized diet. Yes, eating high glycemic index containing foods, then reduced activities, always in front of the TV, we don't play outside anymore, then increase screen time.
Virtual reality. So we get all the excitement but sitting in one place. Sedentary lifestyle.
Yes, so we'll also explain a bit of the energy expenditure in terms of how do you gain or lose weight. So the intake, there's expenditure. What does intake? It contains of all the things you are eating, macro and micronutrients. Whereas the expenditure is based on your activity, which is just a small part. Then the thermogenic effect of food, we can see the second part, also about 10%. That's the energy the body uses to digest food. And then the resting metabolic rate, which takes a huge chunk of the expenditure, and that's largely based on genetics. So that's why you see some people that these people, they eat a lot and they are not gaining weight. Whereas you say some people, I just breathe air and you gain weight. Well, that's not possible. But this may be some of the things that are responsible for this.
Yes, it's okay. So BMI in children, body mass index. So it's calculated, we have the formula. But in pediatrics, just like we said, waist circumference, we classify based on the percentile charts, percentile score. BMI is classified as overweight, obese, normal, then overweight, obese, and severe obesity. If we have percentile charts that we'll display in the next slide, but if the percentile of BMI for that gender and that age is between 85 to 95th percentile, then the child or the adolescent is overweight. Obesity greater than 95th but less than 99th, that is obese. But severe obesity, which something has to be done quickly, is greater than the 99th percentile. So now these are CDC BMI charts, BMI percentile charts. We see for boys in blue and for girls. So percentile charts are gender and age specific, right? So just to bear this in mind. Okay. So how do we manage weight?
In pediatrics. So in pediatric patients, and then a lot of times we need to employ the holistic approach, like I said. You're thinking of the risk factors they have themselves, the social aspects, the psychological aspects. So using the biopsychosocial model. So everything together, because all of those things are leading to each other. So with the dietary components,
Yeah.
even if we can see that from the, we can use the child-born diet, because they said that you can also use it for obesity.
Yes.
So this purpose the need for intervention with dietitian. They also need to come in to counsel the patients and their parents as well. So it's very important for you if you want to change someone's lifestyle, because a lot of these things are bordered around behavioral modifications, right?
Yeah.
So it's very important to go through the trans-theoretical change model, and that is just looking at the different stages in which someone is about to make a decision to change.
Yeah.
Okay, there is the pre-contemplation stage in which, for instance, you have a child with obesity. He doesn't even think it's a problem. If he doesn't even
Unconscious,
think,
unaware.
he doesn't even think it's a beneficial
Yeah.
thing. So you know that child is at the pre-contemplation stage. At the contemplation, okay, he now knows that there are some things that, okay, this is not good for my health, but he still has some excuses. Oh no, I can't do this, or I don't have time. You understand? That's the pre-contemplation. And then the preparation. You understand? The preparation is already making some steps.
Motivated.
To, he's already motivated. He has already started some, but he hasn't really, maybe he has bought, he has registered in the gym. You understand? Then there's the action. He has already started making those changes. So what your counseling does is to move these people, the parents and the pediatric patient, from one stage to the other. So you first have to assess which stage this person is in. Okay, so that's very important in behavioral medication. Then in terms of exercise, exercise is also very important in pediatric weight management. And exercise is just like drug.
Yeah.
When you are prescribing paracetamol, you not just say go and take paracetamol. And a lot of us will just say, oh, increase your exercise. So how do we prescribe exercise? There is a mode for prescribing exercise, and it's fit. That's the frequency, intensity, the timing, and the type. So the frequency, like we said earlier, greater than 5 times or most times. So how many times do you want the person to be doing exercise? Then in terms of intensity, is it moderate? Is it high intensity, low intensity exercise you want them to do? Then the type, is it cardio? Is it resistant training? And then the timing, what's the duration of the exercise you want them to do?
So the physiotherapists will help a lot.
Yes,
Exercise therapists, physiotherapists will
It
help.
will help a lot to be able to individualize the exercise regimen for each person. Then the family components, because we know these are children, adolescents. They're not the ones that will cook. They're not the ones that will cook. So
if you leave them, they'll cook in
So we need the family to be well motivated. So it's not something that you're just counseling the adolescents or the pediatric. You're counseling the parents as well. You can't let them live in. For instance, the parents cannot be eating Burger King, Cold Stone, and then you expect the child to be able to uphold a lot of all these counseling. So it's very important to take this approach. So and we know that a lot of these other things like drugs in adults.
So
is now a very big thing.
You find the adolescents come and say, I need drug for weight loss.
So,
no.
So they have not
no shortcuts. No shortcuts.
In children. So that's why counseling is very important for them.
Yeah. It's okay, fine. So there is this 5210 message for obesity control. I would dare say that parents, this has a lot to do with where we talk about the family. The orientation of the parents matter a lot. I jumped to 2, which is limit screen time to 2 hours or less. It looks like it gives the parents more time to focus on possibly more important activities by giving the children screen to distract them. Now, screen time should be less than 2 hours, right? Now, almost every child you see in clinic comes with iPad that is well padded. So even if he falls on the ground, nothing is wrong with it. So that's one issue. Then encourage no soda or sugar sweetened drinks. I wish to say if we can take polls here to see how many of us listening who are parents who are keeping to this, but that is the truth. We do not want it if we have to control obesity. So participate in at least 1 or more hours of physical activity on a daily basis. That is still different from the exercise prescription of at least 5 times a week, which you can simply say Monday to Friday, right? 30 minutes. So eat at least 5 servings of fruits and vegetables most days. Good. So somebody, a very senior professor asked the question, what is the best fruit to eat? And when training, we came on say, so you mention the one you like, and he watched everybody finish. And we're all wondering why nobody seemed to be getting the answer. And he said, the fruit in season. So the fruit in season is the best fruit. Yeah. So fine. So that's the obesity control using the 5210 model. Yeah.
So cigarette smoking is another chief risk factor, cardiovascular risk factor. I used to tell some of my patients that cigarette smoking is one of those things that if you were to start from every organ, from the mouth to the toe, you find something of bad consequence that cigarette smoking has.
Yes.
So it's actually a very great risk factor for everything apart from cardiovascular. But here we're talking about the cardiovascular. So it's the chief single preventable cause of death, and it's risk factor for cardiac infarction, sudden death, peripheral vascular disease, and lung cancer. So, and like we said earlier, both active and passive smoking,
Both active and
it's
passive.
actually very important. So, and then in the psychosociology of smoking, because a lot of them they start at adolescence, peer pressure, and all
want
this.
to belong.
Yes, they want to belong. And this shisha one that is now like, it's levels now.
Yes, class.
Yes, it's more of a street, okay, that's the thing. So how do we manage? Okay, so in the management of smoking cessation, or all behavioral modification, but we're talking of smoking now, there's what we call the 5 A's of smoking cessation, and it's also similar if you look at it. You ask, of course, you're going to ask the person about smoking, you take the history, pack years, and all how they're funding it and all that. Then you advise, oh, this smoking, and because you said age appropriate counseling, the advice is not going to be telling them, okay, smoking leads to, coronary artery disease. Adolescents don't think of remote future. Like they feel like
even the current packet of cigarettes, see how nasty looking the cancer of the lips. It does
not deter them. So when you're counseling adolescents, you are talking more about things that are now like, okay, your breath, it could affect your breath, your teeth, your nails, and then you understand it could affect the collagen in your skin. You not have what they call this thing, glowing skin.
Yeah.
Those are things that you can use to counsel adolescents.
And the fact that it will keep you away from better people. You miss good relationships.
So those are things that we can use, not talking about coronary artery disease. Then you assess, after you advise this person, you assess which stage of change is this person in based on the Terence theoretical model. Is this still in contemplation, or you move this person? So, and then you assist in moving that person from a lower stage to a higher stage through whichever ways, motivational interview or whatever you want to do. Then you arrange. And because arranging, usually in adults, we can use some other drugs like bupropion, nicotine patch and all this, but these have not been approved for children. So that's why the age appropriate counseling is very important. And it's not something you just say stop smoking, it's something you keep monitoring over time, they keep coming back. A lot of times you can just meet adolescents with substance abuse or smoking, and you just counsel them, and then that is all.
Very good. So smoking goes a lot with other substance abuse. So, and we will see that among all the other risk factors, you want to decrease, you want to reduce, or you want to cease smoking. You want them to cease smoking. Yeah, which may not be a press single button, right? All right. So let's look at childhood hypertension, that which is a fourth cardiometabolic risk. We've talked about dyslipidemias, we talked about obesity, we talked about smoking. So childhood hypertension. So when I measure blood pressure in clinic, I see a reaction in the parents that the children have hypertension also. So what are the definitions of blood pressure categories and the stages of hypertension? Now, this is pediatrics. It's not adult medicine where you have fixed 120/80 and the category. No. But just like every measurement in pediatrics, like we've talked about waist circumference, we've talked about BMI, now we're talking about blood pressure. We have percentile charts for gender and age. So age and gender specific percentile charts. So categorizing blood pressure, we just say, is this child between 1 year to 13 years is one category. How we interpret the reading we make is different from those who are greater than 13 years. So the blood pressure is measured just like we know how to measure, though we'll discuss the best practices in measuring blood pressure. That value that is gotten, we keep it. We now take the height of the child or the adolescent and get the percentile, the height percentile that our adolescent belong to. It is on the basis of that percentile, the gender and the age, we read off the blood pressure percentile that value falls into. So for normal blood pressure, it should be less than 90th percentile for ages 1 to 13. Greater than that, we just want a value that is less than 120/80 for adolescents. Now, blood pressure is elevated if it is greater than or equal to 90th percentile for age and gender, but less than 95th. So between 90th and 95th percentile. That tells us based on percentile. Or now we've said it's elevated, so I've entered between 120, 80, but less than the 95th percentile, whichever one is taken as a lower one, right? So it is stage 1 hypertension by the time it exceeds or it's up to or exceeds 95th percentile, right, as a lower limit, or less than 90% to less than 50 plus 12 millimeters of mercury. So these are reading the blood pressure in children is not just hit and run. No, we do a lot of checking to classify. So also if it's between 130/80 to 139/89, whichever one is lower is taken as a cutoff. By the time we have values greater than the upper limit of the stage 1, which is greater than 95th percentile plus 12 millimeter mercury, or by the time we're getting 140/90, that is stage 2 hypertension. The staging of blood pressure for greater than 13 years is clear. It's similar. It's just once it approximates that of adults, right? Good. So blood pressure measurement frequency. When do we start? So we have this chart showing from age of 1 year. So there are reasons why a 1-year-old may need to have blood pressure measured.
Okay. So usually begin at age 3 years.
Yes.
For otherwise healthy children, right?
Yeah.
And you measure them annually thereafter. However, for obese children, those like the BMI that is greater than 95th, or the ones that have CKD, diabetes, and other things that are on steroids, for instance. So you need to measure them at every visit. Okay.
Yes.
So now looking at those that are now less than 3 years, yes, you're going to measure the BP at every well child visit, and if they are at risk of developing hypertension.
Yeah.
Yes.
So who are those ones? Now there's advancement in prenatal care. Sorry, in neonatal care, right? And it's a perinatal, right? But neonatal care. So you have babies. Okay, we have a baby currently that is 25 weeks gestation, born, and the baby has made significant progress, close to being discharged, right? So babies less than 32 weeks gestation, or those who are small for gestational age, those who are very low birth weight, and we even have extreme low birth weight, right, that survive. Those ones, as from 1 year blood pressure measure, these are part of discharge counseling, right? Good. Now, those who have congenital heart defects, whether it has been repaired or not, we need the blood pressure to be measured, right? Then renal disease. Now, common systemic disease in the environment, sickle cell disease. So a sickle cell disease patient who is 1 year old, 2 years old, should have blood pressure monitored, closely, right? Okay. Now, so we want to see a lot of how do we measure blood pressure. Where everybody measures blood pressure, and in fact, you see, this electronic is now removing a lot of skill from. So you come any cadre of health worker just puts the electronic one. No, what is the best practice for measuring blood pressure? We are talking of using a mercury sphygmomanometer.
So usually the child is supposed to sit down quietly, about 3 to 5 minutes, the back supported, feet uncrossed. You asked me a question, so if I have a 5-year-old, how would I do that?
Okay, no. It's quite. So in our consulting rooms, apart from these chairs, we have those smaller chairs that they like, those fancy ones. So their legs will be on the floor, because if you put a 5-year-old that is not so big on this kind of seat, the legs will be hanging. That is not acceptable. Sorry, by the way, everything we are talking about blood pressure in this presentation is based on the 5th report, right? Best practice, because fourth report is passed, fifth report from 2017. So everything we are saying here is referenceable, right? Good.
So, and then you measure the right arm on the right arm because of
Coaptation.
coaptation of the
Coaptation,
aorta.
yeah. So why this coaptation of the aorta thing? We know that the aorta comes out of the left ventricular flow tract, the root of the aorta where you have the coronary, then the ascending aorta, right? And then the branches are the right subclavian artery, then the arc of the aorta, before you have the other branches that supply the left. Now, good. So on the right, you brachiocephalic trunk. That's on the right. The left, you have the subclavian and common carotid. So at the junction between the arc and the descending, where the ductus arteriosus join, commonly you can have coaptation, which could be preductal or postductal. The point is that, especially if it's postductal, at that point you are going towards the place where the vessels supplying the left is coming from. So, but the right is free. So even if there's coaptation, you get a more reliable measurement that is reflective of what is happening from the heart, from the right arm. Yeah.
So the arm is supposed to be at the heart level.
Yes.
And it should be supported on something,
so
not
on
tell them
on the
do
table.
like this.
Yeah. So we see people taking blood pressure standing up and with the electronic blood BP machine there, with their hand
like this.
oh, no, it
Then it
doesn't.
has to be on the bare arm.
Yes.
So all the clothing should be removed. Then no talking.
No talking.
Yes. Then you auscultate with the bell.
Wow, the bell. So look at this image, this picture here. This is the diaphragm of the stethoscope, whereas this is the bell. So we ask the question: how many times have you, for those who have measured blood pressure in children, where did you use the bell or the diaphragm? Those that went to school daytime use the bell. Those that went to night school use diaphragm. I'm sorry. Yeah, so according to the fifth report, which was also there even in the fourth report, because we did a lot of using the fourth report, but even in the fifth report, it is the bell of the stethoscope that is placed on the brachial artery, which was palpated, and you feel the position in the antecubital fossa, right? So the lower end of the curve is at least 2 to 3 centimeters above the antecubital fossa, at least to give you space for the bell of the stethoscope. So now we inflate not randomly. Like after we've done the palpation method to identify our most likely systolic, we inflate 20 to 30 millimeters of mercury above that point using the radial pulse. And then we deflate not too fast, 2 to 3 millimeters of mercury per second. When we are deflating, the first Korokov sound represents the systolic blood pressure. And the diastolic blood pressure is a last Korokov sound, which is the fifth Korokov sound. But we know that if we've measured blood pressure very often, there are times that you keep hearing the sound, even up to 0 millimeters of mercury. In that case, you use where it muffles, which is the fourth Korokov sound. Yes. Okay. So, yeah.
So talking about the bladder, because we need to see if this figure using this sphygmomanometer is appropriate for that child, because children are of different sizes. So basically, it has to be an objective thing.
Yes.
Okay. So you are measuring from the acromion down
To the olecranon.
You get the midpoint between that.
Yeah.
Then you measure the midpoint
With a tape.
the tape measure. You understand, and you find that you make sure that the bladder is at least 80 to 100% of that midpoint
the
that you
length,
measured.
the length of the bladder.
Yes, the length. Then the width is going to be at least half of it.
Yes. So if it's like what we used to face in short case for part 1 exams, if you need to see that the candidate has a tape, the candidate who is supposed to measure blood pressure has a tape, the candidate does the showmanship to palpate the acromion and the olecranon, right, and get the midpoint, get the mid circumference, and that measurement is taken to the cuff, right, and you measure the length of the bladder, and you are sure it's at least 80% of it, and then you now measure the width, at least 40% of it. That is a definition of appropriate cuff. Remember that from physics, pressure is equal to force over area. So if the area covered is less, right, it means the eventual pressure will be higher. So we get falsely elevated blood pressure readings if we use cuff that is too small for measuring the blood pressure. Okay, fine. So let's talk about treatment.
Yes. So the treatment, that's the dietary approach to stop hypertension.
Yeah, so we've talked about a lot of diets today.
Yes.
Child one,
child
two, for the triglyceride, for the
LDL.
LDL. So now this is DASH diet.
Okay. So these are the components of the DASH diet, but it's also important to be able to materialize it for your patient. So for protein, for instance, we say 1 serving because all of these are in servings. So 1 serving of protein is your pound, like this. And then the carbs, that's the carbohydrate, is 1 fist. And then the vegetables and fruits is also 1 fist. Then for the fats and oil is a thumb. Just a thumb. Then the nuts is a cupped hand. So that those all those I'm saying is servings. Then for the 2,300 milligram of salt is 1 tablespoon. So ask yourself if
so we are closing and we are going home. The swallow will take that is carbohydrate. Does this make sense? Yeah. So, but that's the size that should be taken. Yeah. All right. And that is per day. That is assuming that's per day. Okay, we'll try. All right. So pharmacological treatment. So we'll do dietary therapy, dietary approach to stop hypertension, then drug treatment. The first one is lifestyle and diet. So generally, angiotensin converting enzyme inhibitors and angiotensin receptor blockers with calcium channel blockers are good with thiazide direct as first line, not propranolol, not beta blockers, right? And the same recommendation goes when there is background conditions like DM or kidney disease. Okay.
So now we'll be asking, how are you going to screen for all this? We talked about so many of the risk factors. So what's the time? Do we start screening everybody from 1 or what? So now the universal screening for children at least is between 9 to 11 years, right? So from 9 to 11 years, they have the strongest correlation between results here and adult life. So because we know in puberty, that's the peak of where, like we said, cholesterol is not all bad. It's used as a precursor in hormones, and you know, there's a lot of
hormonal activity
during that. Yes, so that's why you need to measure at this age, and then additionally, you now measure thereafter. That's 17 to 21 years. So then selective screening for children of other age groups, like we said, other people that have the risk factors, cardiovascular risk factors. Of course, we may need to start earlier.
Yeah, like the obese, those who are already obese, those who have family history.
Yes. So, and then it's either the fasting or the non-fasting lipid that we use.
Yes. Yeah, we could use either of it. Okay. So we really appreciate you, dear listeners. We are getting to the end of our presentation. What are the guidelines for preventive pediatric cardiology? Looking at the risk factors that we've discussed today and looking at the goals of treatment we want to achieve. I jumped straight to cigarette smoking. I said our target is complete cessation of smoking for the parents, for the children, for their parents that may serve as a bad influence in the smoking, and then for relatives who may influence them. And I dare say also for even their peers, their mates, because peer pressure is a whole lot of problems, right? So cholesterol is elevated or borderline based on the values we can see on the screen, and the target values are stated. For systolic and diastolic blood pressure, we want less than 90 because that is what is appropriate. That's remember in the table we discussed, less than 90 that is normal blood pressure. Yeah, fine. The same for weight and BMI. Yeah, it's all right. So we've talked about this slide in the course of our discussion so far. Anyway, but to put it together, cardiometabolic risks does not rest solely on the shoulder of one expert. And so we need a lot of collaboration among teams, right? So while the pediatrician or the family physician is meeting this child in clinic and will give initial care and coordination of the entire team, other team members are important. Just imagine telling me to prescribe child one diet. I know there's something called child one. Let the dietitian do their work now, right? So we refer them to the dietitian. So there are some specialized nurses for behavioral modification that we talked about in weight loss. The psychologists become very important.
Yes, and cognitive behavioral therapy,
Yes.
hypnotherapy, they're very, very important and have been shown, evidence-based to be shown in the management of weight loss, hypertension, and they are very effective.
Yeah. So for treatment, weight control is necessary across board. Across board. Dietary intervention, child one, child two, dietary approach to stop hypertension, the promotion of active lifestyle. This will help to maintain optimum weight and normalize, keep to the range of normal blood pressure and normal lipid profile. Yeah, so we are concluding.
Yes.
Yeah, so we know that seek and you shall find, right? So if you seek for cardiometabolic risks in children, we hope that so far we've stimulated our audience enough to know that it is beyond full blood count and MP. Even if that child required full blood count and MP, and that's what brought them, it's beyond infectious disease treatment, right? So if we look for this, we'll find it. So look for family history, you will likely get it. Look for social history, smoking, substance use. Okay? Then anthropometry is of utmost importance because you have to classify. The thing is, we have this situation where parents who are aware of it want to lose weight, but they want the children to look chubby so that it looks like a good status symbol that this parent is doing well. Anthropometry will tell us the truth because we classify those children. And then please let's measure blood pressure. If you find a child 3 years and above, measure. But if it's a child that has those risk factors we discussed, like less than 32 weeks of gestation, small for gestational age, children with who had umbilical artery catheterized in neonatal line, and all the other risk factors, sickle cell disease below 3 years, right? Measure. Now, every patient encounter is an opportunity to counsel them on healthy lifestyle practices.
Yes. To add to that, I think in summary, we can say if we use the biopsychosocial model
Yeah.
and the patient-centered care model,
Patient-centered.
you understand, because every opportunity in the patient center is not just about the disease. We're not being paternalistic. Look
Yeah.
at the background and every other thing of the patient. So look into all those areas of the patient's life. So be able to provide holistic care and prevent, hopefully reduce the burden
Yeah.
of
So,
cardiovascular disease
yeah,
in Nigeria and Africa.
yeah, because you see our initial slide introductory, almost 70%, the risk cluster of risk factors. So thank you, dear listeners, for your rapt attention and following us closely.